Good morning, everyone. I'm the project manager for the Austin Health Choosing Wisely project. And while as part of the project we've covered a wide range of areas, and we plan to cover a wide range of areas, today I'm focusing on coagulation studies, which was our first topic area. The project involves four medical clinicians that work as our clinical leads. We have Dr. Simon Judkins as our committee chair and a highly enthusiastic steering committee with representation from all clinical groups at the hospital. So why reduce coagulation studies? So our project was based on the Choosing Wisely recommendation from the Australasian College of Emergency Medicine that states that coagulation studies should only be requested under specific clinical indications. On the Austin ordering system, coagulation studies are grouped of these four tests, and it's a very common test that's ordered in quite high frequencies at Austin. Thorough review of the evidence and consultation with heads of departments determined that there is actually positive evidence to support the use or the prescribing of all four tests in many clinical situations. So how big was the problem at Austin? We were averaging at about 701 tests a week, with 54% of these being ordered by junior medical staff. So what did we do? In order to address the high frequency and volume of tests, we aim to establish a multifaceted behaviour change strategy. And this is in line with the evidence that suggests that such approaches are more successful in resulting in behaviour change, but also in sustaining these changes. So to assess the size of the problem, we examined the volume of tests being ordered across the hospital. At Austin, we're very fortunate to have a wonderful data system that allows us to easily extract this data. And we were able to feed back the data to the top 10 ordering units. And this was done in the form of a report. It was anonymised in that the unit was able to see where they stood in the ranking of 10, but not necessarily know where the other units were. In addition, for each of these top 10 units, we did a case audit of 100 consecutive patients that had been ordered coagulation studies, all four, and to examine the indications for why the tests had been ordered, and then this data was also fed back to the heads of the departments. We're going to repeat this process towards the end of the year to see, determine if there have been any changes, and also to feed back to the heads of the units about any successes they've had. Second key change was in changing our online ordering system. So at the Austin, we use Cerner, and we've got two levels of changes that we're making, soft stops and hard stops. So our soft stops is what we've done so far, and that's a pop-up message when a clinician does order the coag studies. The message comes up with a question asking if they're sure they want to have all four tests ordered, and there's also a direct link to our updated guidelines. The next stage will be perhaps to, and we're still investigating, to have a look at removing coags as a group altogether and having them as separate tests. In the meantime, what we've been able to do is remove coags from the list of common tests. Education and peer support has been a key component of our behaviour change strategy, and this is particularly for junior medical staff. And what we did is we took advantage of hospital orientation sessions taking place at the beginning of the year for nurses, junior medical staff and returning HMOs. We've also had a series of grand round presentations for all clinical staff, as well as case-based learning sessions at lunchtime. Lastly, we updated the existing coagulation studies pathology guidelines, and this was really just streamlining what was existing to make it very clear to clinicians the specific clinical situations where components of coags would be required. We also developed, as you can see on the screen, a flowchart that summarised this information. It's very easily accessible for clinicians. Another component has been doing a multivariate analysis to see what factors are associated with overordering of coagulation studies. So we looked at how many admissions patients had within a 3-month period, and these are patients that had had 10 or more coags ordered, the number of prescribers, the number of wards they were admitted to, and the average variation of their INR, APTT, PT and fibrinogen from the normal ranges. What we found was that when holding all things into consideration, number of prescribers was found to be statistically significant with the high volume of coags ordered. And with every new prescriber that the patient had during their admission or during their stay of 3 months or more, their number of coags ordered increased by 5. So how are we going so far? This is a repeat of the data I showed on a previous slide. But here in red is what's happened since we started our coagulation studies area. We've had a decrease of 35% in coagulation studies. And I did check this data against volume for the past 5 years to make sure it wasn't a seasonality change. Definitely isn't. 503 is the lowest we've had thus far. And it's we've had a lot of positive feedback. We look at this data every week. It's collected every week. And it's really helping us to plan the next stages for the project. So the lessons learnt. As I said, we're looking at a series of topic areas for choosing wisely, and by having targeted behaviour strategies with different activities, we're pilot testing different strategies that we will take forward to the next topic areas. An element that we have factored into the success we've seen so far is based on the ability to engage medical staff during their orientation period so that they start with a clean slate with these new recommendations. In addition, we timed our policy updates with this, as well as our electronic ordering system changes. For existing staff members in the hospital, we found that feedback has really allowed the discussion to be had on all levels of clinicians, junior staff and consultants, about how their wards and units are going in this area. The literature has demonstrated that sustainability is enhanced through the implementation of forced function. So they're the changes that we made to Cerner. And so that's what we've done with our electronic ordering system. We're always gaining feedback from clinicians on the changes we make, and we're keen to minimise alert fatigue. So we keep monitoring this and gaining feedback from our clinicians to make sure that these changes are working for them. Of course, having an engaged and enthusiastic group of clinicians is key to spreading the message of choosing wisely across the hospital and through our partner organisations. And so we're taking this into account as we move forward as how we can further engage other hospitals in our area. We've shown great success, and we're optimistic that the changes observed will be sustained, and we'll be taking many of these strategies through to our next topic of urine cultures. Thank you.